Everyone, and welcome to today's webinar, Beyond Policy, How Leadership Gaps in Sterile Processing Become Accreditation and Infection Prevention Risks. Our speaker today is Jameed Billingsley, Executive Director of Surgical Services, Strategy and Performance of ASSI. At this time, all lines have been placed on mute to prevent any background noise. We will have a question and answer period at the end of the presentation. Type your questions using the question prompt. They'll be answered in the order they were received. Please identify the name of your organization at the beginning of your entry. As a reminder, this webinar is being recorded and will be available in the CIHQ YouTube library within a few days. It's now my pleasure to turn the conference over to our presenter, Jameed. You have the floor.
Good afternoon, Michelle. Great seeing you again, and great seeing all of my CIHQ HACP-PICs and all of our other professionals that are joining. Today, we're going to talk about how leadership gaps in medical device processing become accreditation and infection prevention risk. This is going to be a fun presentation, and I hope to get a lot of questions because it's a topic that impacts us a lot, but a lot of times we don't know what we can do to help. So you'll know after this. A little bit about me. I'm a Navy trained. I started off as a field medical corpsman. I became a surgical tech. I became a first assistant. And then I fell in love with sterile processing. Then I fell in love with infection prevention. So I was certified through CIHQ as an infection control professional, and I love it. Who's this session for? IP professionals, surgical services leaders, medical device reprocessing leaders, clinical leadership in areas that use medical devices, and healthcare executive. Notice we say medical device reprocessing leaders, not just sterile processing, because a lot of times when we talk about the gaps in our oversight, leadership, and policies, we are so focused on SPD, we forget about the TEE probes, the ultrasound probes, the endo, the clinics, the end users like L&D that store and receive instruments, sometimes without training. So what we're going to talk about is all the gaps that can exist throughout our organization and facility, no matter how big or even small. Even at an ASC, you need to make sure that we're filling in those gaps. Our learning objectives for today is we're going to identify how medical device reprocessing leadership failures create direct infection prevention risk. We're going to understand why just having a policy is not the same as having a quality program with control of your processes to ensure that the same thing is done every time. We're also going to recognize the operational warning signs that tell you whether you're a surgical services professional, a C-suite leader, or infection preventionist, hey, I need to jump in and help. And then we're going to build the language to escalate these concerns to hospital leadership, to surgical services leadership, even directly to the medical device leader themselves. And then we're going to walk away with some specific tracer questions and examples of some policy and leadership gaps that we can start an action plan on next Monday or even this Friday. So let's connect leadership and policy gaps to risk, right? The first thing I want to say before we get started is leadership gaps is not an insult on the leaders of these device processing areas. A leadership gap doesn't mean you're a bad leader. It just means there's an area that you are not grading in yet. And so the whole purpose of this presentation is to identify those areas and then help those leaders grow as you grow, no matter where you work. A leadership gap is the space between what the policy says and what the process actually produces under pressure, right? Not just on the low census day or the low case days. In medical device processing, policy is not a protection unless leaders can prove process control. Are we following the IFUs? Does the team use SDSs when appropriate? And can the team even access the policies that we're thinking are protecting us? Many departments have easy to complete competencies. So if your competencies are easy to complete, then how do they breed the confidence under pressure that you need? I always say competency is ability plus confidence, right? Like if you can do it, you have to have the confidence to do it. And if your competency is just to check out, you didn't challenge the team member to feel like I got it, right? And a lot of times departments are missing a CMS compliant quality program with KPIs and accompanying corrective action plans. We often take false comfort in policies that are out of date, not aligned to the newest standards, not aligned to the technology changes, right? One of the quick checks that you can do from your desk when you finish this thing, hey, go ask your medical device processing, hey, what does your policy say about robotics? Robotics is probably the biggest growth since the last time the policy was written to now. And if it's not in the policy, that means there's nothing governing the practice, and we're relying on local knowledge or orientation or precepting to provide that instead of us controlling what we do. And what happens? Infection prevention ends up struggling to help, right? Surgical services has not always been the best of friends or the most welcoming to IPs. But then the IPs own the consequences when they have to write the action plans, when they have to, when the C-suite is saying, hey, what are you guys doing down there? And so part of that is we want to be proactive and start partnering with our medical device processing areas so that we have an action plan and that we're working towards something. All right. Well, I think my place is pretty good. I don't know if I have any of these leadership gaps that you're talking about. All right. Well, let's talk about it and see if you have any of these things going on. So, are the competencies as strong in the other areas, dental clinics, endoscopy, TE processing, ultrasound processing, as the ones in SPD? Are the ones in SPD even challenging, right? The clinic areas that store, use, and transport medical device, they don't have a training, right? So all of us have been there on either a mock survey and a real survey, and you go to a clinic and you're like, you can't store these instruments like this. Well, guess what? That happens when there's no rounding, quality control, or training going on because they're not storing it like that to get us in trouble on purpose. Nobody has rounded, nobody has given training on how to get better at that. Policies are treated as hallowed historical documents. Oh, we shall not challenge the policy that was written in 1978. We just update it every year. Yeah, we do an annual or every 3 year. Policies need to be looked at with a skeptical view. Is this still true? Do the IFUs still support this? Are industry standards still saying it? And are we even referencing the latest industry standard? One of the things that I think is helpful for IPs to learn surgical services is when AORN comes out every year and AMI comes out, depending on the particular area of subject matter, it may come out every 3 to 5 years. But let's go over it with our medical device reprocessing leaders to make sure that we are all on the same page, that our policy still aligns with the standards that are out, right? And so when you start doing that, one, you start learning, but also, believe it or not, because of operational pressure, a lot of times medical device leaders don't have time to do that kind of book club study of the standards. And so they may be unintentionally out of standards. What does it also look like from a CMS perspective? We're going to talk about CMS because whether you're accredited by DMV, Joint Commission, CIHQ, AAAHC, they all are deemed by CMS. So they all have to be compliant to CMS standards. So a lot of times we concentrate on CMS and work our way out. We're familiar with clients that have all those different accreditations, but the CMS ones kind of trump them. Policy drift. So a policy exists, but it's outdated. The references on the policy are from the previous version of that policy. Then you might have practice drift. Policy is good, but they're not doing what the policy says. The competencies don't even match the policies. Orientation doesn't match the policies. Then you have proof drift. Yeah, we're doing this. Okay, where's the documentation? Whether it's a scan in an instrument tracking system, a logbook, how do we prove that we're doing these required steps, right? And then the learning drift, right? So when we treat every process failure as a one-off or a discipline issue, then we lose that opportunity to do a good RCA and figure out, are there other factors that contributed? Did we have the infrastructure in place to make doing the right thing the only choice or the easiest choice and not taking shortcuts? So let's talk a little bit about weak or outdated policies. We have weak or outdated policies, that equals built-in variation, which equals patient safety risk, right? So the weak policy creates false confidence. Leaders think we're covered, but the process drifts quietly away from what the policy says, right? The other thing is that the policy can drift away from what evidence-based industry standards are, right? So part of safety science, right? So these are some references, and all these references are listed at the end, but here's a little one. When drift becomes normal in the Journal of Patient Safety, when doing wrong feels so right. So when you normalize shortcuts and deviance from what the policy says or what our expectations are, then it's really hard to get back because you're doing it 4 different ways and you don't have a policy review with new people. How many people on orientation have a part where we go over, and I know I'm not saying give them the policy and go, here, like the newspaper, read that, but how many of us have time that we say, here's one of our key things in our policies, right? We expect you to do this every time. AMI ST90, which is the quality document standard in AMI parlance, it talks about how policies are not enough. When you don't have document control, you're not performing audits, and you're not doing corrective actions and making sure that it doesn't happen again. So CAPA, when you see that term CAPA, that means corrective actions, preventative actions. So we don't want to just correct the actions. We want to make sure it doesn't happen again. And increased risk from incomplete records, lack of traceability, and nonconformities. So these are references that are saying this is what happened when we have a disconnect between our practice and our policy. CEC in 2008 talked about that the evidence that the risk is real is inconsistent cleaning, incomplete drying, rush relief, weak traceability, and delayed detection are a huge risk associated with weak or outdated policies. Patient safety risk from outdated and misaligned processing instructions. The FDA in 2015 talked about that risk when we have either outdated or misaligned processing instructions. ARN, the latest version, talks about how policies must be rooted in evidence-based recommendations. That's ARN's trademark, and actively maintained by undergoing regular review to incorporate the latest evidence and address evolving practices by interdisciplinary team. So that's one of your first kind of warning signs. Do we have an interdisciplinary team? How strong is it? And are all the people that need to be on it involved, right? I've been to a lot of infection prevention meetings in my career. And a lot of times you have the endo leader missing. You have the leader of the department that does TEE probes. You have L&D missing. Those are all OR suites. Those are all heavy medical device departments. And so even though they may report differently up the hierarchy, they still need to be in the same meeting when we're talking about medical device processing. So let's talk about CMS compliant quality program. If you ask me what's one thing that can help fill the leadership gaps, it is implementing a CMS compliant quality program. Because a lot of times, I'm going to pull back the curtain a little bit. A lot of times, you know how for nurse leaders, when they get promoted to a leadership position, the hospital has great courses for them. Other kind of non-clinical leaders may not have those classes. Or a lot of times if the manager gets hired from outside the organization, they're already a manager, so they don't have to go through those courses. But guess what? At the place they came from, they didn't go through those courses. So a lot of times the leadership gap comes from a lack of knowledge of what we need to focus on. The other thing is, as an IP and a surgical services leaders, as you guys are working together to build up your quality program, you're going to identify gaps and opportunities for improvement. So that's a fun journey. So for those who are not familiar with what a CMS compliant QAPI program is, it's really riffing off of the quality management system information in AMI ST90. And CMS requires that we use references such as AMI AORN and CDC to develop our quality program. Quality program failures lead to infections, surgical delays, and device damage. And so, as a part of the CMS COPs, the conditions of participation, um, it is required to have a quality program. Every hospital has a quality program. Every facility, even ASCs, have quality program. The problem is, so we got our CLAPSs, right? We're monitoring those central lines. We got our CAUTIs. We're monitoring those urinary catheters. But the highest risk area throughout the entire organization is medical device reprocessing, whether it's in SPD or endo or any of the other places that handle medical device. They're responsible for 72% of findings on accreditation surveys. So shouldn't they have, right along your CLAPSy and your hand hygiene monitoring and your CAUTI, you should have a quality program in sterile processing. So I think developing that program is a great journey for both surgical services leaders, device leaders, and IP to come together to develop this program to be in compliance with CMS, but also it will help fill in the leadership gap. Conditions of participation are the things that you have to do to continue to receive Medicare, Medicaid, unless you're a plastic surgery outpatient place. 96% of your patients have some form of Medicare, Medicaid. If you lose your accreditation from CMS, then the private insurance will stop reimbursing, and in the course of a few weeks, you won't be a facility anymore. So I don't say that to scare you. I just wanted to. We all know how serious immediate threat finding is, but the most likely area to get immediate threat finding, we don't have a quality program going. I'm here to tell you, let's start some quality programs, and that'll help fill in these leadership gaps. The risk is not imaginary, right? In the CMS QSO 23 09, QAPI, a quality program, is the third most frequently cited CMS finding. Guess what? The second most common. It's the infection prevention, and it's very, very, very focused on medical device reprocessing. And then the fourth finding, I should say, is surgical services. And again, a lot of it is associated with point of use treatment and the whole medical device process, whether it's overuse of IUSS or what have you. So this is a serious issue, and we want to use our CMS quality program to help us fill in these leadership gaps, right? Why every infection preventionist should care about medical device oversight. So again, we just said quality programs are a mandate, CMS mandate. Absent quality directly fuel the emerging lack of oversight survey finding. So when you get a lack of oversight survey finding, it's typically because either you've had a finding, maybe from your accreditation agency, and CMS comes, the first thing they're going to ask you is about your quality program. And if you don't have a quality program, or if some of that stuff that you're reporting that we did 176 cases and 1,000 instruments, those are not quality metrics, right? And you're going to find yourself with a lack of oversight finding. You know how we know? 75% of our business is helping respond and develop evidence of compliance for people who already had a finding. Only 25% of our business is people like you saying, hey, can you come in and take a look so we can get to the right place? So we have done several evidence of compliance to help facilities save their accreditation, but we would love it if you started working on it before you get to that point. Complaints from dissatisfied employees or customers, right? Whether it's social media, the generational differences, customers are more likely to directly contact the accreditation agencies. Disgruntled employees are more likely. And the best defense you have when you get an accreditation visit, just to know, if somebody calls CMS, they have to come. They can't say, you know what, that was a crank caller. That sounds like somebody who didn't get a promotion. They have to come, no matter what the source of the complaint is. And the best defense you can have there is not a perfect operations, but yes, we already have a quality program and we're working on that. Why is it so great when IP brings their holistic spirit? IP can see the forest, not just the trees. I can tell you, as a former operational manager, you are so focused on what you have to, the overwhelming amount of work you have to do every day in medical device processing, whether you're in endo, whether you're in L&D, whether you're in TE probes, and certainly when you're in sterile processing, that you are focused on those trees. And IPs can be our partner that helps us see the kind of forest, right? They can link the whole life cycle to SSI trends. They can recognize trends that impact multiple departments, right? We're focused on our water being bad. Then they go, hey, I was looking at the sinks and TE probes and they look kind of cloudy. So those are the kind of things that can help. And as IP rounds, they learn more, they see more, and they can actually connect better. So that's a role that really comes through. So one of the things that CMS looks for, and just if you're going to have a quality program, you have to have data, is what KPIs are you reporting? I can tell you the most common opportunity for improvement is we're reporting lagging only. So if you are a HACP-IC, you remember from that certification exam, we talked about outcome and process KPIs. So lagging is the same as outcome. So lagging KPIs are like the main goal. We want to reduce IUSS. We want to lower bioburden. And a lot of times that's the only KPI we report. And when we do that, we kind of do ourselves a disservice because you miss that opportunity that process our leading KPIs to measure the effectiveness of the guardrails that lead to it, right? So right now, we're only reporting our IUSS rate or our bioburden rate. But if we started reporting like total processing time, percentage of sets turned around daily, OR medical device processing leadership approval for IUSS, right? That would help us with our IUSS. If we were trying to reduce lowering bioburden, the OR point of use treatment compliance, ultrasonic compliance, washer cycle compliance, proactive QAs. So again, process and lagging. Right now, most people are so concentrated on those outcome or lagging KPIs that they don't give themselves a chance to catch things before they get out of control, right? So if you're reporting both, you can connect that cause effect, not just report. You can separate the noise from the process. And then you can actually catch things that are kind of running off track or getting out of the guardrails before it becomes an actual problem that you report out as the big one. Here's a dashboard. This is just a sample dashboard. The things I want you to think about is not too many things at one time, right? I've seen a dashboard. One of my team members, she's so great, so smart. I'm not going to say any names, Freddie. But sometimes her dashboards are so busy that I need help interpreting them. So I'm like, the client cannot read this. So let's keep the main thing. And that's where IP and surgical services partnerships come in, because a lot of times when you're in surgical services or medical device reprocessing, you are focused on what you think is the problem, and then working together with the operating room to identify what they think are the problems can help you develop a dashboard that really focuses on the things that impact patient safety the most. That doesn't mean the other issues that you have in your department don't need to be taken care of, but a lot of times, one of the things when I was a baby manager, I wasted a lot of times on the things that I thought needed being fixed instead of working with the OR to make sure that we work together on things that need to be fixed. Excuse me. So here's going to be a little fun exercise. Here's some examples of medical device process and leadership gaps, and then which of those CMS conditions of participation that go unnoticed until survey time. So weak competency validation. We have easy competencies. Actually, they're just checklists, and people self-sign them off, and they say, "I'm ready to go." Well, this is going to hit the quality, the QAPI condition of participating, because we can't demonstrate process improvement for documented issues, right? So when you start asking, of course, they're going to ask the manager, but then they want to make sure that the team members are a part of that quality program. I remember when I first started a quality program, I was really doing it by myself. And what happened was I'm focused, I'm stressed out, and the team wasn't on there. So part of when you have a good competency that connects the policies, procedures, and the things you want to do, everybody on the team is able to speak to them. The next one that you'll find under the IP setting is inconsistent HLD and sterile training validation for high-risk tasks. So you may have multiple sites and they're focused on different things. They have different levels of high-level disinfection training. The competencies all look different. So if you have different competencies, you have different practices, which gives you different results. The next one that you'll find under the surgical condition of participation, instrument readies and error issues drive IUSS, and there's not clear rejection criteria. We've all been there where the OR is rejecting stuff because we're on a bad run. We created that bad run. We had some bioburden, we had some missing instruments. Now the OR is like, yeah, if you tow this up to the light with a microscope and then you get an electron spectrum, turn the UV light on, and we get one of those Batman spotlights. You can see right here, here's a spot. And that's never a good place to be for either the OR side or SPD. But that comes when our training is not strong to reject things that don't quite meet the standards, right? And so the operational fallout, you start having case delays, rework, patient risk, increased tension, and lower trust between the departments. How about poor IFUs, SDS, and policy access? The most common mistake we make is, no, we have the IFUs on we have a software that does the IFUs. Okay, can everybody in here access it? Oh, no, we have the policies. The policies on a share drive. Okay, can everybody who works there get to the share drive? Oh, no, the SDSs are on the main page on the intranet. If the people can't get there, it's like if the tree falls in the forest and nobody's around, does it make a sound? Having those things available is not the same as having everybody able to access those, right? And so a lot of times we don't have revision control, right? Sometimes our policies are not up to date. The key documents are in place, but the staff cannot demonstrate access or provide evidence of update. And on the surgical side, that means new devices are not properly vetted, right? So we might need a different ultrasonic to process these new robotic arms. But that got missed because we don't have our policies that say device processing leaders have to be on the value analysis committee. Variation runs amok across shifts, not just the organization, but even every shift. When your record traceability is not strong, the organization has no reliable way to link processing to the patients. Process failures occur, but are not consistently tied to effective patients. And then the operational fallout is recalls become chaotic. And there's a lot of times that you have recalls, and If you do a recall before it touches the patient, then that's a close call. That's a lesson learned. We want to do an RCA on that. But if we don't have quality traceability, we're not able to execute. So then now we are doing, instead of doing a recall process, now we're doing a patient notification process. That's how critical having that traceability in your policies and being a leader on that. The theoretical oversight without rounding. Listen, policies look good on paper. Even on the Zoom meeting, everybody's like, no, our area is good. But if we don't set foot in those areas, you can't, you don't want the first person that doesn't work in that department to lay eyes on that department to be somebody from the survey team. So these are just some examples of kind of how some of these issues can end up with findings in all three of the main areas we talked about as being associated with medical device reprocessing. All right. So we're going to take a note, take a step, take a little second, and now we're going to have some fun because we're going to talk about some frequently found policy leadership gaps and how IP and surgical services can jump in and fix them. So this is not a list of every single opportunity that exists in the world, but what it is the frequently found. We were blessed to do 154 departments clinical assessments last year. So we have the data. We have the data. So these are not just, when we read it somewhere, we Googled it or chat GPT'd it. These are really literally from the data that we had from 154 departments that we surveyed last year, right? And just some little tools that you can use to fix them if there's are occurring at your gaps. I promise you, at least one of these is occurring at your facility. And if like all of them are occurring, call me immediately. Joking. All right. So one of the big ones is IFU noncompliance. When we don't have annual review of IFUs, and what happens is practice are based on local training versus IFUs, right? So Sarah told me to do it like this. We didn't use the IFUs. The policy didn't say we have to use the IFUs. And so the leadership gap comes because there's no direct connection to IFUs during the orientation. One of the things you can do as a leader or IP is go down and say, hey, show me in your orientation part where we go over how to look through the IFUs and how to access IFUs, right? When changes happen, so a lot of times if we're relying on paper log, you'll have one log that has the newer policy and one of them that has a 3-year-old policy, right? And then we missed that opportunity for feasibility testing, right? We just copied and paste our policy from Google or Chat GPT or from a policy at another place or our old place, but it may not be feasible with the equipment that we have now, right? What happens during a survey? You find out that just having the software with all the IFUs in it, that's not compliance, right? Because they're going to say, show me what you're doing and show me where in the IFU that it says do that. And now you find yourself in that part. So what can we do as IP or surgical services professionals? Hey, let's check to see, do they do annual IFU reviews? Oh, no, we review them every 3 years. That's not enough, right? Audit the staff's ability to access, right? Volunteer to help run IFU location drills. I found this out the hard way. Luckily, it was during a mock survey and not a real survey. We had all the passwords trained. We put it as a part of our annual training. Everybody did it. And then we had a mock survey, and one of my team members just couldn't do it, even with the password on there, because they were doing a flexible scope because they had got used to going through the instrument tracking system, not going directly to the software. Luckily, we had a poster on the wall that showed those directions, and I was looking up, and she was able to see it. But the point was, my lesson learned after that is once a year during the annual training is not enough. We have to hit this a little more frequently. The next leadership gap opportunity is sometimes we treat washers like magical cleaning devices. So we get mad when the surgeons ask us to sterilize wrenches from Home Depot or things that they invented, spoons that they hammered and cut in their garage. But we kind of do the same thing with washers, right? So the policy doesn't talk about rejection criteria for running items on the wrong cycle. There's an I cycle for ophthalmic instruments that don't get lubrication, that should not get um, enzymatic. Orthopedic cycles have longer thermal rinses, longer soak parts, and sometimes we're called into the bio burden. And the end of the first day, like we audited 31 washer cycles, every single with orthopedic instruments on them. Every single one of them was run on the plain instrument cycle. Um, One of the other things is the IFUs for the washers tell you that you have to clean a filter, and unfortunately you have to screw those arms off. And when you do that, you just dump it out, and you're going to find out a kind of tip protectors and chemical indicators, or you have to weekly, every 3 days. Some of them don't say you have to degas, right? And if the policy doesn't say do that, then guess what? The team is going to be so operationally focused that they're going to miss that step. And you don't want to. You want to help them get that. Again, leadership gap. Sometimes we use the cheaper, easy to pass quality control test on the washers, right? And then even then, we don't use it on all levels as the IFUs require. We don't track loading and cycle selection compliance. We don't scan to or from the washers. So that what if all your SSIs were from, you had 5 washers and it was from washer number 2? That would be some great information to be able to give to the IPs. And as an IP, you need to start saying, have we thought about scanning to or from the washer? I prefer scanning on the clean side because the decon team is working already hard enough. Uh, and what happens during the survey? Well, the washer IFUs are very clear and easy. You don't have to be some subject matter expert like Jeremy from DMV to find that one. The IFUs are pretty straightforward, and you can tell if the filter has been cleaned. You can tell if the racks have been washed off, and then you can easily watch to see them put vendor trays in there and press instrument. The lack of washer compliance documentation is also a major vulnerability. Hey, did you clean those spray arms like the IFU said? Yeah, we do it every day. Where? How do we know that it's done? So again, what can IPs do? Recommend scans for these actions, right? Because if we put scans for these actions, it's still easy to perform. You don't have to make a log in decon that can't come out of decon, but that can document that the performance of those actions. And by the way, as an IP, if you're the IP assigned to surgical services and medical device reprocessing, you absolutely should have an admin level access to the instrument tracking system so that you can learn. Because a lot of times the IP is relying on an overwhelmed manager or leader to help them get access, right? And so rejection scans is such a big thing. That's a whole nother presentation. But when you talk about why is our Ferrari so perfect, well, on the commercial they show the guy with his glasses and the micrometer. It's really because they reject everything. This tail light, 0.00 millimeters off, get it out of here. And so if we can start adapting that rejection mentality in medical device reprocessing, I promise you our HAIs will go down, our SSIs will go down, and our errors. Next one, point of use treatment compliance. That is now a leadership finding. I think we all know that, but it's unacceptable to say we don't have a program to monitor and report on our point of use compliance. Um, the biggest policy miss that you see when the point of use treatment that is in the policy is written only to the OR. But you get every time labor and delivery, wound clinic, all your other customers, they still have an obligation to do that point of use treatment, not from what Jamid says, not even from what Amy or ARN say, who also says the same thing, but the device. The device IFUs say that. We also don't address transport delays outside of endo. Like if we have endo, it's like if you get outside that hour, you have to do enhanced processing. And you go, yeah, that makes total sense. Why don't we do enhanced processing when we have those long delays in the operating room? Same theory, biofilm forms on top of biofilm, on top of biofilm. I saw an interesting presentation at HSPA how sometimes when you get rid of biofilm, that was the biofilm that was covering up the other layer of biofilm, right? And a lot of times we don't treat point of use compliance as a key performance indicator. Um, the leadership gap is we don't make it easy for our team members to rate point of use and transportation compliance on receipt. It's going to take some work in that instrument tracking system to set it up. But if I have to just scan acceptable, not acceptable, improperly stacked sharps, whatever that is, then you can have real-time data instead of relying on snapping the shot pictures, right? And then what happens during the survey? Point of use treatment questions, documentations, and observations are low-hanging fruit. Every accreditation surveyor is familiar with that, and that's just a quick ask. What do you guys do when somebody doesn't have point of use transportation? Please don't say whip out my cell phone, my own personal cell phone, and take it into the department, right? And so again, IPs need to have admin level access to instrument tracking system. You can insist on adding mandatory point of use training rating. So a lot of times it's sitting on the phone, and the manager may not have time to do that. But working together to get that tracking in there can save you from a very, very common finding. Wet packs and wet loads. One of the things that we do wrong is we treat every wet pack and wet load as an isolated event. We don't usually call it a repair vendor. If it passes the next biological, we back up and running, baby. Oh no, that was just because Sarah was working the washer, or the Johnny left too much water. Every time we have a wet load, it needs to be documented, and that should be in the policy, right? A lot of times we don't know how to use kind of logic to distinguish wet loads from wet trays, right? And the simple way is start off with the heaviest stuff. I can't tell you how many times we had one wet tray, and then we popped every item in that load, and some of it was vendor trays that were needed for cases that were already scheduled that day. Not another drop of moisture in there, right? So kind of write that into the policies. And what happens during the survey? Well, the first part is we don't have our tray weights in the instrument tracking system. We also don't program the available sterilizer max weight. And then staff is unable to verbalize the wet load process. One of the things IPs can work on is help create that wet load versus wet tray recall and notification algorithm, and have that posted by the sterilizer. I don't have to log into the computer. I can just follow along to do it. Required at every wet event, even those caught before the patients, be reported to IP. So a lot of times they go, oh, I see some moisture. We pop the thing. We tear apart the whole load. We on the thing. We just act like the load didn't happen. We may send the load back to decon or do it over and just rewrap the stuff. But why do we need to notify IP? We caught it. It was no big deal. But guess what? If every shift just does that 2 times during the whole year, you had 6 wet load incidents, and we didn't report any of them. So then when you have one that you don't catch, it's like, hey, we never had any wet loads. We did. We just didn't report them. And that's what's important. IUSS, or shortened dry time for convenience, equals a QAPI failure signal. All right. So IUSS, we know. We used to call it FLAS. Shortened dry times. Depending on your accreditation agency, what I know is exactly what the FDA says about it. I know exactly what DMV says about it, and I know exactly what the Joint Commission says about it. So don't let the vendor tell you something that you may not be able to defend on surveys. So one of the things in policies that have been very effective is SPD and OR leadership agreeing before IUSS is run. One of the things that we see when people have findings for IUSS is a lot of just in case IUSS running that can be reduced. Reason codes. Reason codes are so important because you need to have an internal IUSS reduction committee, which is a leadership gap that we see not having. Can you give me your IUSS list and show me the POs for the orders that so we can get those off. Remember the multi-society statement on IUSS when we changed from Flash to IUSS? The bottom line when you read that is every IUSS is a lack of a surgical instrument inventory. So we can have all these reasons around it, but we need to start reducing it. No, ours is good. We're only at 1.97. Well, if you had a QAPI program, you would say, well, we want to get 1.97 down to 0, right? And so what you can do as a IP, make sure that they're running their IUSS rate per case as recommended by AORN, not total instruments. Oh, we did 5 IUSSs today, but that was okay because we did 112,000 instruments, so we have a low IUSS rate. The physicians are like, I only come here every Wednesday, and every time I come here, we have to IUSS something. That's where we don't have the match, right? And start our enhanced IUSS reduction committee identified the things that they need to order. All right. Another one, staff protection. This is a big one, right? So we say we are all for the staff. We want to protect the staff. But then when you go there, staff cannot locate the SDS. Staff cannot tell you what's the hazards of the dangerous chemicals that they're using in decon and even on the clean side with low temperature sterilization. Their policy doesn't comply with the new AAMI ST58. Just came out, was a pleasure to work on, but we have the old document in the department and where our practices are based on the old document. PPE not enforced. We go do rounds and we go, oh, you guys can wear dangly earrings? Oh, you can just, the front of your hair has some invisible cover? Like PPE is not enforced and it's often stored in the aerosolization zone. Ofsted study showed that the aerosolization zone is not 32 inches, not 36 inches. It can be up to 7 feet, right? And chemical monitoring for peracetic acid, hydrogen peroxide sterilization is absent. Can't say you're there to protect the staff and you don't have any monitoring. Why does this fail surveys? Listen, we're not trying to be mean to microorganisms. We're not trying to chasten. We're trying to kill microorganisms. So these are dangerous chemicals, and our team deserves protection, right? And the staff needs to know where the protection is. So one of the things IPs can do is, and if you at the end, I'll share so you can email me. If you want Ofsted study, we'll send it to you. Review the new ST58 and volunteer to run SDS and spill kit. That's another common finding. The staff doesn't know where it is or how to use it. Lack of quality in the education plan. Competencies don't have return demonstrations. There's no separate competency for complex instruments. We go like, oh, we're having a big bioburden problem. Then we come to the department and somebody on their 3rd week in the department is doing an ortho tray. That probably doesn't match. You have the ability with your instrument tracking system to say, you can't do these trays until you get to this level of competencies. Use that. Orientation is not typically well defined. Checklists are treated as real training. Biggest one that leaders pressure to get new staff off orientation. Is Jill ready yet? She's been here almost 3 weeks. She can do decon by herself. Bah. And what you've been calling competencies look like checklists to surveyors. Education not up to date with the current technology. Again, you're doing robotics. You don't have any education for robotics. You're doing spine trays. You don't have any education required before you can complete spine trays. IPs treat competencies as a tracer. Say, show me the education record, then show me the newest product you have and show me all the education for everybody who's here. More than likely, your department will have a problem with that. And you just keep doing that until they can comply, right? And then ask about competencies for high risk skills lists. Like, what are the trays that you have the most errors? What are the tasks that you're missing? Do we have a separate competency to make sure that we know how to do it? Traceability gaps, again. Do we let pill packs and vendor trays go on as Cynthia's tray number 1 or the exact one? One other thing, we don't have count sheets for our vendor trays. No count sheets. That means no tip sheets or comments in there. And also, you're not getting the credit for processing those. Only a select group can perform recalls. When you have a recall, and I'm not talking about during a survey, somebody from the OR says, hey, the lot sticker came off my thing. Can you reprint me a new lot sticker? And we go, oh, the manager's at a meeting. When he gets back, we'll get it printed. And they're like, no, no, we have a case. We got a patient that's getting ready to come in the room now, and I need this sticker for the implant. That happens all the time, and we can fix that, right? Patient traceability is important, and what you can do as an IP, audit the sterilization records. Keep an eye on the pill pouches. Do they say general pill pouches, or do they say Atson forceps? Do they say the bakies? And volunteer to run quarterly drills until the staff demonstrates their competency. The medical device processing or storage transport areas without oversight. So we're talking about all the other areas that use medical devices. The biggest myth, well, the procedures are not sterile, so we don't have to be as tight as SPD. The assumption that clinical certifications or license cover them even for processing. Yeah, they have their license or they have their certification. What happens during surveys? Guess what? The team, they can't even find the IFUs to prove that they're compliant with them, but their competencies for clinical people is only on the clinical side, none on the reprocessing side. So as an IP, we need to form a governance committee so that we're all on the same page. Those areas don't have to recreate the wheel. Sterile processing could deliver some transport and point of use education that's documented and in their records. IP can round and kind of audit their process, look at their training, help them develop training for the reprocessing side that goes with the clinical side. Medical device water quality. What happens is a lot of times we're all working on our water quality in SPD, and we're doing a decent job. But what happens about the water for TE probe reprocessing? It has a standard. What about the water for the AERs in endo? It has a standard, and we're not even testing that water. So really, it starts off by medical device leaders not being on the water committee. And what happens during the survey? Staff cannot answer the simple question: how do you know this water is in standard? Leaders cannot produce water quality requirements and proof because facilities has that and we never asked for it. What IP can do? Join the water committee and bring the medical device process. Not just SPD, but every department that uses medical devices has water requirements in their IFUs, right? And then develop a water control plan to get in compliance with ST 108. The last one that we're going to talk about is oversight of environmental controls. This is a big weakness. Organization treats central monitoring as a reason that each department doesn't need to have their own temperature and humidity monitoring, right? And what happens is clinical areas lack proof of environmental compliance. Every clinical area has a certain range that they have to be in to reprocess those devices. And it's different by IFUs, different by AMI standards, but ASHRAE 170 sets the temperatures for those areas. But guess what? If you don't have any way to check it, that's not saying this takes the place of central monitoring. What it's saying is if you don't have the ability to say, no, we're in good temperature, that's a bad thing. And so one of the things that IPs can do is one thing, encourage disinfectable signage be put in place wherever you have any temp or humidity things. And if you don't have some, you get the unofficial ones and say, no, these are not the official measures. This is so that we can just visually make sure that our area is within our temperature range and we have this parameter guide so we know it. Those are two things that we can really improve. The summary is leadership gaps in medical device process don't stay there. They show up in infection prevention. They show up in C-suite meetings, and unfortunately, in modern times, they show up on the internet and on social media. Infection preventionists who understand it, the workflow can be great advocates and partners. Uh, IP, stop asking, do you have a policy, and say, show me how the workflow and the control matches the policy that we have. You already have some leadership gaps to get you started. Just start with one. Don't go back and overwhelm your medical device partners by going, yeah, we're going through all these. But walk through, ask for the policy, see if the policy is updated, and work together with them to come up with some great solutions or some great starts. Does anybody have any questions?
All right, Jameed, we've got one question, whether the slides will be provided. Would you mind sharing them with me, and I'll drop them into the attachment box. Thank you.
Of course. That's an easy breezy question.
Thank you. Let's see, and remember that this has been recorded, and we will post to the CIHQ-ARS YouTube channel. Thank you, Jameed. And here's his contact information. And we will definitely see you at the summit. Hold tight for the slides. I'll check my email.
Please feel free to reach out to me. Michelle is going to have the slides. I can send the slides. If you have some questions about any of the things we mentioned, I know it was a lot, but the purpose was really to give you some ideas that really hit home and where you can start to make a difference. So thank you. All the references are on the slide. I'm going to leave the QR code up. If you don't have the QR code, please reach out. There's not a lot of Jameeds. In fact, there's only one other one that copied my name when I was a kid. My mom didn't like that. But anyway, reach out, JHMEID on LinkedIn. Let's connect on LinkedIn. Let's talk. I can come talk at your facility. If you have, we've done several APIC events. If you have a medical device reprocessing event, I can help you there. I love helping people. I love kind of pushing you to areas that you haven't thought about going before. So I hope that you had a chance and enjoyed this talk. Is there another question that came up? No, already.
Yes, sir. Monica, will you drop your email address into the chat box, and I'll make sure that we get those slides to you. My email is running. Oh, looks like they just came through. Okay, and well, I'll make sure that they're provided.
And again, if you have any follow-up questions, the great thing is our CIHQ is incredible. They're going to put this on YouTube. You can go back and refer to it. You can watch it with your medical device reprocessing. You can watch it with your IP brothers and sisters. You can kind of look at it and say, yeah, that's boring. That's the part. So that's the exciting.
All right, young man. The slides have not come through yet. It must be a pretty good size file. So Monica, I'll hold on here for your email. And oh, there it is. Oh, and we've got lots of folks that want the slides. Yes, I'll hang on, and Jameed, once they come through, I'll get them sent to everyone that has requested. And all right, thanks. Yes, absolutely, Deborah, got you. Andrew, yes, sir. All right. Thanks again, Jameed, for your time.
It's always a pleasure working with our partners at CIHQ, and I'll see you guys at the next event.
Yes, at the event in October. Thanks, Jameed.
Bye-bye.
All right, hang in there, everyone. I've got your emails. All right, everyone, if you have to go, that's just fine. I'll hold this call up until I receive the slides, and I'll make sure that everyone gets them. Thanks again for your time.